Achieving and maintaining optimal lipid levels is one of the principal goals for both primary and secondary prevention of cardiovascular disease. Individuals at high and very high cardiovascular risk are the main patient groups recommended for both non-pharmacologic and pharmacologic lipid managements and are expected to obtain the greatest benefits. However, for individuals at a low cardiovascular risk, reduction in lipid levels is often underemphasized. The takeaway message of this article is that in individuals without dyslipidemia and with a low cardiovascular risk burden, higher cholesterol levels were associated with the increased prevalence of atherosclerosis and increased future risk of cardiovascular disease. Hi, my name is Zhen Zhou, a postdoctoral research fellow working at Mandy's Institute of Medical Research, University of Tasmania in Australia. On behalf of my co-authors, it's my great privilege to present our recent work entitled Impact of Blood Lipids on 10-Year Cardiovascular Risk in Individuals Without Dyslipidemia and with Low Risk Factor Burden, to be published in the October issue of Mayo Clinical Proceedings. Our study focused on the individuals who had no prior history of cardiovascular disease, dyslipidemia, and other conventional modifiable cardiovascular risk factors, including current smoking, hypertension, and diabetes. The study aimed to determine the cross-sectional association between multiple lipid biomarkers and the atherosclerosis, which is defined by the presence of either coronary artery calcification or the presence of cirrhotic plaque. And we investigated the longitudinal association between lipid markers and 10-year risk of incident cardiovascular disease. Data of participants in this study was extracted from the MESA study cohort. MESA is a prospective multi-ethnic cohort study that involved 6,814 men and women aged 45 to 84 years who were free of manifested cardiovascular disease from 6 United States communities between 2000 to 2002. We included 1,204 participants who met our inclusion criteria. The median age of study cohort was 54 years old, and about one-third had detected coronary artery calcification at baseline. The median 10-year PCE-CVD risk of the study cohort was 2.7%, and the mean LDL cholesterol level was 112 mg per deciliter. We find that 43% of the study individuals had atherosclerotic plaque at baseline. One standard deviation higher LDL cholesterol levels, which is equal to 23.4 mg per deciliter, is associated with 8% increased chance of having atherosclerosis at baseline, 11% increased chance of having coronary calcification, and 13% increased chance of having cirrhotic plaque at baseline. Similar trend was also found for total cholesterol, non-HDL cholesterol, and the composite lipid parameters. The restricted cubic splice showed a monotonically elevated 10-year risk of incident cardiovascular disease with increasing LDL cholesterol and non-HDL cholesterol levels, and with decreasing HDL cholesterol levels. This demonstrated a continuum of risk for subclinical atherosclerosis and cardiovascular disease among healthy persons with lipid levels that do not meet the currently accepted criteria for dyslipidemia. The Cox regression further revealed that a one standard deviation higher baseline LDL cholesterol was associated with increased risk of incident cardiovascular events by 40%. Similar association was also found for other lipid variables except for triglycerides. Higher HDL cholesterol was also associated with lower cardiovascular risk. We also did a sensitivity analysis in a subcohort excluding individuals with obesity, and the result was generally comparable to our main study findings. Despite the widely accepted notion of the less strict lipid control in lower risk group in clinical practice, our results suggest that a further reduction in lipid levels, even in those at low risk and with acceptable lipid levels may confer additional cardiovascular benefits, especially among those with existing subclinical atherosclerosis. In another word, the maximum tolerated reduction in lipids is likely to be associated with the best clinical outcomes. Due to the inherent limitation of the observational study, future randomized trials are needed to assess the efficacy of both pharmacological and non-pharmacological lipid-lowering strategies in preventing the development and progression of atherosclerosis, as well as the incident cardiovascular disease over long term in populations with low severity risk burden.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.